Hello, my name is Jason Aldred. I'm a board-certified neurologist and movement disorder specialist based out of Spokane, Washington. I am an owner of Selkirk Neurology and Inland Northwest Research based in downtown Spokane, Washington. This presentation is for the 2001 National Northwest Parkinson's Foundation Hope Conference. I've been asked to present this by the NWPF on their behalf regarding an update on deep brain stimulation. I want to thank the NWPF for all they do for the greater Northwest area, our patients here in Spokane locally, as well as throughout the region. It's really a tremendous organization. And I very much appreciate being offered an opportunity to update you all on deep brain stimulation. Just a brief bit about our practice. Selkirk Neurology is one of the largest movement disorder centers in the Inland Northwest. We're a referral center through Central Washington and Central Montana. Myself, movement disorders neurologist and movement disorder nurse practitioners work in our clinic. And we're well networked with physical therapy, OT, speech therapy, as well as Parkinson's boxing programs in the region, which hopefully we start to be seeing more of here in the near future. Also, we're the host of the Spokane DBS program, which is a collaborative effort between Sacred Heart and Multicare here in our Spokane region. Inland Northwest Research is a clinical trials division of Selkirk Neurology. It's the largest clinical trials center for Parkinson's disease in the Northwest, drawing from Spokane, Seattle, Portland, and Western Montana, and Idaho, Northern Idaho. We focus on experimental therapies for disease-modifying symptomatic oral, subcutaneous infusion therapy, deep brain stimulation, and botulinum toxin for movement disorders. We run phases 1, 2, 3, all throughout the spectrum of types of clinical trials focused on movement disorders and Parkinson's. Today, I'm going to talk about what deep brain stimulation is, who the surgery is for, how the surgery may help you or your loved one, and what happens in surgery, as well as advances in DBS treatment. Deep brain stimulation has really been around for quite a while now. First approved in 1997. It's been around for over 2 decades. It's one of the more important FDA-approved treatments for movement disorders and Parkinson's disease, essential tremor, and dystonia. It's a medical device. It's implanted into the brain with a thin wire deep into the brain and on the scalp, underneath the scalp, and underneath the skin with the pulse generator implanted underneath the clavicle. This unit is completely self-contained underneath the skin inside the body, so there's nothing outside of the body. It's important to know. It works with medications to improve symptoms in Parkinson's disease. It's important to understand. We say that the medication and the electrical treatment DBS work better together than either do by themselves once the patient has progressed to the point where they have wearing off of their medicine throughout the day. We don't know exactly how deep brain stimulation works, but we have an idea about possible ways it could work. And one of the better explanations is that an abnormal electrical signal comes about from the changes in the brain with Parkinson's disease, and deep brain stimulation electrically jams the abnormal signal. So the normal electrical signal emerges again, which results in improved slowness, stiffness, and tremor. I notice I didn't just say tremor, but also the slowness and stiffness seen in Parkinson's that can affect the hands as well as the legs and feet. With Parkinson's disease, the brain makes less dopamine over time. Even in normal aging, it does that. But in Parkinson's, this process is vastly accelerated. And then wearing off and dyskinesia will begin when levodopa, one of our main medications used to treat Parkinson's, is used over time. Because of the progression of Parkinson's disease, this occurs. Not simply the medicine itself, but the progression along with the medication, the brain seeing levodopa triggers dyskinesia, and the lack of levodopa or the lowered amounts of levodopa throughout the day trigger the wearing off episodes. Here's an example of severe dyskinesia in Parkinson's disease.
This is my triple trick. I have very bad dyskinesia. I'm raining all around. But if I can just calm myself down I can stop it. As long as I want it to, except when I speak. So as soon as I start doing something, it comes back in, but I can last quite a long time.
So that was an example of dyskinesia, involuntary movement that happens otherwise when the medication is working well in the on state. So you move better, but move too much. And that's an unavoidable complication of having Parkinson's disease and having it treated otherwise appropriately. Even with the right dose of medication, the brain becomes sensitive to the lack of dopamine and the lack of movement. It produces more movement, but excessive movement at times. It's not always bothersome. The example I've chosen to display here is a more severe dyskinesia. And you can see that Tom, when he's quiet and calm, it will lessen. And when he's more irritated, agitated, or trying to talk, doing something else, the dyskinesia will emerge. So who is deep brain stimulation for? Well, it's for people with Parkinson's disease. That may sound a little obvious for this talk, but the idea is there are some mimics of Parkinson's disease. There's vascular Parkinsonism. There's what's called atypical Parkinsonism, conditions that you may not have heard of, but like multiple system atrophy, progressive supranuclear palsy, that can mimic Parkinson's. And DBS is not for those patients with those other more rare disorders that mimic Parkinson's. DBS ideally is for people that are benefiting from medication, usually levodopa, typically, although plus or minus other medications as well. Most people have a trial of levodopa at least, and they're having wearing off or dyskinesia or one or the other or both, or maybe have a unique medication intolerance that's kind of unique to them, but they're otherwise generally benefiting from medicine. The levodopa wears off and is less reliable, and that's where DBS really shines. It takes the medication effect, your best medicine effect, and kind of continues that evenly, whereas before with the oral meds, it was up and down, up and down. Levodopa works well again, but results in bothersome dyskinesia, and that's the abnormal involuntary movement that we just saw. Other special situations where deep brain stimulation may be considered is if levodopa helps the slow movement and stiffness, but doesn't help tremor. DBS may help this better than medication alone, but you see in this case, there's still some benefit with the levodopa. Another situation is if levodopa hasn't really had a chance to work, and that may be in a small percentage of people who take L-dopa with Parkinson's, and they have they're exquisitely sensitive, very sensitive to the nausea from levodopa, or maybe they have low blood pressure. And levodopa is triggering these Parkinson's symptoms, making them worse. And for whatever reason, despite multiple attempts by the movement disorder neurologists, they're struggling, and they maybe have a special candidacy for levodopa. But you want to make sure that the person has true, regular, idiopathic Parkinson's disease and not a mimic, and generally has a response to levodopa that's meaningful and not lasting as long as it should. So how will deep brain stimulation help? Well, I've mentioned this a little bit already. It helps the symptoms improve by levodopa, but the stimulator helps the symptoms more consistently. There's improvement in the on-off symptoms. The on time with medication sometimes goes along with dyskinesia, but with DBS, what we're able to do is use the medication, but use a lower dose, whereas before the surgery, the medication is a higher dose. After the surgery, the medication is a lower dose. And when you're able to get by with less medicine, generally you have fewer medicine side effects such as dyskinesia, and getting the stimulator to kind of fill in for the gap that the medicine provided the benefit in otherwise. Medication is still beneficial, so it should not be stopped in almost all cases, although there are a handful of special cases that might be the situation needed. Here's an example of wearing off treated with deep brain stimulation, and in fact, a patient from our own clinic.
See important safety information at the end of the video. Only your doctor can determine if this therapy is right for you.
Here you see a person with Parkinson's who stands from a seat with some assistance, stiff, arm swing is decreased. Notice there's no tremor, but appears to have a lot of difficulty walking in a straight line.
Side to side. Kind of like a step.
You see when this patient is trying to turn, there's a freezing of gait. This is when the medication is off and his DBS is off as well. It's almost frozen in place. And this is, if you've experienced this, you know how horrible this can be. It can happen suddenly. It can happen in a predictable way before each dose of medicine.
Step, 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 step.
And now you can see on the right side of the screen, the same person off medication with the DBS turned on. You see how much better he is in terms of being able to walk and stand and turn.
See importance.
So here, it's important also to note what DBS does not help. Except for tremor, symptoms that are not improved by levodopa, they don't get better with DBS. So for example, if your walking difficulty doesn't get better with levodopa, it won't improve with DBS as a rule. If your type of slow movement, if you're slow without your, very slow without your meds, but still somewhat slow with your medication, otherwise feeling better with your medicine, but still somewhat slow, you'll still have that type of slowness with DBS. So based on how your Parkinson's symptoms respond to levodopa, you can predict with a good degree of accuracy how your response and improvement might be with deep brain stimulation. Cognitive impairment is another concern. Sometimes patients will come in with a question of if DBS will help their thinking difficulties, and in fact the answer is no, and unfortunately it will even make it worse. If you have a significant thinking difficulty, DBS can worsen that. If a person has no thinking difficulty or perhaps very minor, mild thinking difficulty, they do fine with DBS, but we do avoid offering it for cognitive impairment because not only does it not help that, it can make it worse. Again, walking difficulty not improved by levodopa does not get better with DBS. And then the many non-motor symptoms of Parkinson's. This is the iceberg picture, if you've seen that, the low blood pressure, bowel, bladder, mood, cognition, sleep disorders. Those do not generally get better with DBS because they're not levodopa responsive symptoms. So what's the risk of DBS? If my patients don't ask me, I prompt them with this comment when we're talking about deep brain stimulation surgery. I say, well, you know, you want to know what could go wrong, right? What's the most likely bad thing that could happen to you? And that's a reasonable thing. It's a procedure. Something's being done to your body. And there are risks, like any intervention. Medications, there's risk as well, of course. The most common complication is infection. It's the most often significant complication seen in maybe about 3 out of 100 patients. When this happens, generally everything has to be removed. Sometimes we're able to, the surgeon, I should say, is able to treat this with antibiotics, IV or oral antibiotics, and can keep the device in place if it's caught early. But in the rare times it happens, commonly it must be removed. Now, fortunately, it can be put back in usually within about a matter of 3 months or so once the infection's treated. And the vast majority of people want to put back in as soon as possible because they've seen the benefit. Stroke is possible. It's very rare. If it occurs, it's usually the hemorrhagic stroke or a bleeding type stroke and not an ischemic stroke. And often there is significant improvement after that. But of course, you know, we do everything possible to avoid that. The surgeon, in fact, takes a preoperative MRI scan and looks carefully at the pathway, the trajectory that they're going in the brain, and looks to see if there's any blood vessels there that are obvious and to avoid those. So there's a lot of preoperative planning that goes into ahead of time into the procedure, so that when the procedure is actually being performed, it's really quite straightforward and fairly quick. Worsening depression. If someone has active depression, DBS can make that worse. So we don't operate on people that have active depression. Depression, you're probably aware, is common in Parkinson's as a non-motor symptom, and it's if we didn't offer surgery to anyone with a history of depression, it would be very few people, because it's so common in routine life, and even more so in Parkinson's. But the idea here is that someone's not actively depressed, or they have a history of this, then the symptoms are well controlled. Or if they have been recently depressed significantly, then they have a care plan in place with behavioral health, psychiatrist, something of that order. And I mentioned this already, but to mention again, worsening cognition. If there's moderate or severe thinking difficulties, we in our program do not offer deep brain stimulation for those patients. It's not an option. So what's new in DBS? Originally the Medtronic system, as we kind of call the legacy system now, has been around since 1997. It's durable. It's had a long track history, and it's a good reason that it's continued to be used. A lot of pros for that. In 2015, the St. Jude Abbott system was approved with their Infinity DBS device, first one allowing directional steering. The Boston Scientific device followed shortly thereafter in 2017 with their Precise DBS device. The Medtronic Percept DBS device has come out last year in 2020. That device has programming technology with the BrainSense recording system, patient diary. It doesn't do directional steering. And then in 2021, the Boston Scientific Genus DBS device was released, which shares the prior Boston Scientific availability for directional steering, and has a unique type of system called multiple independent current control, which the result of this is it sort of turns the entire DBS probe, if you will, into a virtual contact, rather than having to use each contact individually. You have the use of the entire contact with the MICC. The most recent Boston Scientific device is Bluetooth enabled, rechargeable, and again has directional steering and the multiple independent current control. So again, the Medtronic device, most of you who are watching this presentation probably have the Medtronic device, and all of these devices are excellent, by the way. You really can't go wrong in terms of them being shown to be effective and durable and really excellent DBS therapy options for patients. The Medtronic device was in 1997, first came out. It's an established technology, it's MRI compatible. And the new device has the 2020 BrainSense technology to assist in programming. I've got a picture here of the doctor programmer you may have seen, and the old one at least. There's a new one out now. Patient handheld, and then what the device looks like. And here I have a picture of what the BrainSense technology looks like, where there's a patient diary here where they took the medication, and also recordings of areas deep inside the brain while the patient's using the device. It's set for a period of time, recorded, and then the provider can analyze this. It's very new technology. More to come about this in the future. The St. Jude Abbott DBS device, picture of it here. It's got more of a modern programmer. That's the programmer here, the doctor programmer. Directional steering is made possible by the unique nature of the DBS lead. And really, a lot of patients like the very convenient kind of iPhone patient programmer that's set up with the St. Jude Infinity app to connect with the device. So here is a layout of the Boston Scientific the systems. The original Precise DBS system, which had the multiple independent current control, long battery life with its rechargeable battery of over 15 years, or at least 15 years in the US. Smaller IPGs, and then the Cartesia directional control lead came out in 2019. These are the vast majority of the ones we've implanted to date of the Boston Scientific here in Spokane. The MRI is conditionally approved for the Gevia models, and the very unique patient programmer that allows providers to shape the field curve and shape the field from simply a round ball, which we'll see in just a minute, to more of fitting it exactly to the location they need within their brain programmed. And then very excited as here in 2021, the Vercise Genus DBS system has been released, and that's 5 MRI conditional approved IPGs. That means you can go in MRI with any of these programmers or devices. Wireless Bluetooth connection to make the connection easier. Before we had to kind of stand a little closer with patients, and then be able to specifically visualize a person's anatomy with these programming systems. So a bit about this virtual contact and the Cartesia leads here, the Boston Scientific. I'm going to spend a little bit on this. Precisely shaping and steering the stimulation where it's needed most can give you more flexibility to have the brain programmed to get the best benefit with the fewest side effects. And that's with medication, anything. That's what we're looking for any therapy. You can really, before, if you can kind of see these bands here around this probe, these are the areas we would stimulate. Now, due to some pretty sophisticated electrical engineering, the charges are able to be delivered along the entire span of this lead, rather than just at each single contact here. So it can adapt. We call that multipolar stimulation. Here's a video of directional steering I thought you all would find interesting, and it kind of hits home the difference. The first part of the video, before I play this, I want to explain it. The first part of the video shows what we call omnidirectional, which means that was the original way DBS was designed, where you're just going 1, 2, 3, 4 for each level of the leads. And then you'll start to see that it moves around and is shaped around the probe. And that's what we see with the directional steering, particularly in this model, our example, the virtual contact effect of the Boston Scientific device. So here's turning 1, the second group, and the third group, fourth group on. That's the standard traditional way of doing it. Now here is the new way, where you see we turn it on and see how the energy is moved around side to side. In a perfect world, our neurosurgery colleagues would have it placed just perfectly for individual patients' needs. But in reality, even with a surgeon placing the electrode perfectly, sometimes we find, it's just like our bodies, our brains vary individually from person to person. And even if it looks like it's absolutely perfectly placed, once a DBS programmer like myself or a nurse practitioner, once one of us gets programming the actual device in a person's brain, we find that there could be some individual effects and variations, effects on speech, walking, things like that might be better if we had more precise control over the electrical stimulation. Here you see the green structure is like a nucleus, we call it. It's the target in the brain, and you can put it more into that direct nucleus and keep it away from areas that you don't need it on. So a bit about what happens in surgery. So the surgical consultation itself occurs. We refer here, Dr. Carlson and our Sacred Heart surgical team is the site for a DBS placement here in the Spokane Coeur d'Alene area. So after I see, or Jamie Mark, our nurse practitioner, Dr. Manick is on our team as well. He's at Providence now. After one of us sees a patient, we'll put a referral into Dr. Carlson, and we have neuropsychological testing performed, and then a surgical consultation. There's a preoperative evaluation, and then surgery. So the day before they have the MRI, prior to placing a halo on a person's head, it's a big kind of frame, and a CAT scan. And then during the surgery, which is performed, by the way, for Parkinson's patients, for the majority, surgery is performed when you're awake. And we do that to record the electrical firing of the brain in different areas that the electrode passes through. The effect of hearing the different areas. It's like kind of imagine going through Europe on a train, and you don't know any of the European languages, non-English languages, but the train stops, you get off the train, and you can kind of tell you're in Germany, you can kind of tell you're in France, you can kind of tell you're in Poland, even if you don't know the language. Well, that's kind of what we're doing with our microelectrode recording. We're passing through the targeted areas, and then we're doubly ensuring not only is the electrode that is being placed going to where it looks like it should be visually. But we also are using our ears and listening to the sounds of the nerve cells firing to ensure that the electrical target and the visual target are the same. And so that's why great care is taken, and we have a very skilled team here in our Spokane DBS program that performs this. So about a week after the actual wire, the DBS wire, which is the first part put in, the wire is put in and a little devices, little wires put behind the ear, all underneath the skin. Then a person will come back and they have an incision beneath their collarbone area, and Dr. Carlson implants the pulse generator there. That's kind of the brains of the whole operation. There's the wire, and then there's the computer part, and that part is underneath the clavicle. And the DBS wire and pulse generator are connected on that day. About 2 weeks after that is a post-operative visit with the neurosurgeon, and it says here 1 to 3 months. Typically, it's about a month, actually 3 to 4 weeks even. Deep brain stimulation will occur with myself here in clinic at Selkirk Neurology, or Jamie Mark here at Selkirk, or Dr. Manick at Sacred Heart. And then periodically is adjusted over time. Like anything, it's when it's first used, it's, you have to kind of adjust it a couple times over the first few months, and frequent adjustments of DBS over the long term are pretty unusual. In common practice, the most common frequency of the DBS follow-up is around 3 months. Many patients 6 months. Some patients go much less often than that. We don't necessarily like that, but it is kind of in a way, I think, a testament to this therapy working very well. They almost kind of forget that it's there. Although with the newer models, of course, you have to recharge them. But inevitably, if you live long enough with Parkinson's, you'll have to have this replaced. But with the newer models, the Boston Scientific model in particular, these are lasting a terribly long time. I say terrible, but this is like an exceptionally long time, I should say. And people are able to get back more to their normal life. One word about the way that the DBS workup is done. Sometimes patients come to our program and we explain how we do it, which is having movement disorders neurologist see the patient, determine that the diagnosis is correct, because we're always second guessing the diagnosis. Hopefully I've explained why it's important to have an absolute certainty in the diagnosis. And we select the patients for surgery. What that also involves is selecting the proper location in the brain. There's a couple different targets, 3 different targets in the brain that can be that the lead can be directed towards. And based on the type of symptom, the response to levodopa, difficulty with dyskinesia, the targets vary considerably. You will see it done in other programs, kind of a one-size-fits-all. They always put it in the same place. We don't really practice that here. We feel that a more individualized patient approach is needed, and that's kind of how most larger programs do it. They vary quite a bit based on the patient's needs. The other important part of the team approach is after your DBS surgery is completed, you still require medical care. You still require programming of the device. You don't just set it and forget it. You need to adjust it over time. Adjusting medication is important as well. I mean, ideally you want to get off the right medication, stay on the right medication as well. And so that's important. And the knowledge of how medication works is best done in a movement disorders type clinic. Our DBS neurosurgeon, again, along with the movement disorders neurologist, selects the patient for DBS surgery and does the handiwork of placing the DBS unit safely and effectively. Our neuropsychologist, Dr. Wald here in our program, cognitive and behavioral assessments before surgery and sometimes after surgery. And if we, Dr. Wald is really very skilled and trained at a world-class program down in Florida. And if she oftentimes will, or sometimes will bring up items from her neuropsychological assessment that we as the neurosurgeon and neurologist weren't aware of. And occasionally there's safety issues with mood or depression. Sometimes we'll think a patient is very cognitively normal, but perhaps we missed some important clues about their cognitive health. And we'll sometimes recalibrate how we do surgery, or perhaps even sometimes decline a patient for surgery based on findings of this multidisciplinary approach. And I have a picture of us all kind of sitting at a table, but I thought that this would be neat because this is Dr. Wald, Jamie Mark, Dr. Carlson, myself, Boston Scientific representative, and also a group of doctors that came from China to see us a few years ago. We've hosted physicians from China a number of times to train at our program, both neurosurgeons and neurologists. because of what they feel is the quality of teaching. And so I just thought this was kind of a happy picture of people being together out in a hotel before COVID, and certainly we've missed all of this human interaction and having guests from other parts of the world, and I can't wait to get back to that. So our DBS program did go on a brief hiatus during the COVID peak, and now fortunately things are back in full swing, and we can't wait to continue our work and collaborate and bring this very exciting therapy to the people in Spokane, Coeur d'Alene, and Tri-Cities, and all of our inland Northwest region. So I hope you've enjoyed this overview of DBS and update, and thanks for your attention.